Welcome to the lecture about hemophilia. This is a dysfunctional clotting disorder. I put a copy of this YouTube link. It's actually not a YouTube. This is just a website that gives you a nice overview of what hemophilia is, but I'm going to give you the bulk of it in the lecture. So the problem with hemophilia is they are lacking a factor that's required in the clotting cascade. And you should have learned the clotting cascade when in physiology, but you've promptly forgotten it. For hemophilia, they are lacking either factor 8 or factor 9, and they really have different names. Factor 8 is hemophilia, factor 9 is Christmas disease. Both are an X-linked recessive disorder, so the mothers carry it, and it's expressed in the males. Now, although this is an X-linked recessive disorder, about 1/3 of the new cases are from a new genetic mutation. These children will present with bleeding, hemarthrosis, and prolonged bleeding after procedures. So here I have broken down the three most common bleeding disorders. So once again, factor 8 is hemophilia A. Hemophilia B is also known as Christmas disease, and it's a factor 9 deficiency. And then we have von Willebrand factor disease. So they're fine with factor 8 and factor 9, but what they're missing is the von Willebrand factor. When they classify the severity of the disease, they can actually quantify the amount of factor that they have on board in case they have a bleed. So mild disease, they have between 5 to 40% of the normal factor present. And so we would anticipate them bleeding if they had a major trauma or surgery. Moderate expression of the disease is when they have only 1 to 5% of the normal levels of the factor. And now with this, only mild trauma, so just something like falling off of your bike or falling on the playground or having surgery will result in a bleeding episode. And those who have a severe disorder only have 1% or less of factor activity available, and so these kids can have a spontaneous bleed even without hurting themselves. The hallmark signs and symptoms is hemarthrosis, and this is bleeding into a joint space. Older children have reported that when they have a bleed into the joint space, they feel a burning or a tingling first, and then they feel the swelling and they see the swelling. The most common sites, and this is in a descending order, so this is the frequency of what joints are you going to see where these kids come in. Number 1 is the knee, number 2 is the elbow, and then those are all followed by ankles, shoulders, wrists, and the last is hips. I put this YouTube video up in your 2 watch videos, and this is about I think it's close to 14 minutes, an adolescent story of what it's been like living with hemophilia all of his life. In fact, both of the videos that I have posted about hemophilia show Caucasian children, but hemophilia is expressed across all ethnicities. Diagnostic testing for hemophilia is finding a prolonged PTT. That's all we have to see. They have a normal PT. And then they will do the clotting factors to identify which particular disorder they have. Are they von Willebrand factor deficient? Are they factor 8 deficient? Or are they factor 9 deficient? Now, mind you, there are other factor deficiencies, but these are the 3 most common. When we do an assessment, there can be a history of bleeding. Because remember, if they have close to 50% of factor, the bleeding can be minimal, and when kids fall, they bruise and they bleed. So the parents might report that, I think that they do bleed a little bit more. They had more bruising than their siblings did. Then they can have active bleeding, and that's coming out the nose, the mouth. It can be in the stools, and it can be in the urine. But one of the first red flags, and these would be kids who are probably moderate to severely deficient, is in a male, they will have bleeding with circumcision. And so when the pediatrician or the obstetrician, whoever's doing this notices that this kid won't stop bleeding, they will start investigating for hemophilia. If we never find out until a girl goes through adolescence, her disease may be expressed by having excessively heavy periods, and that's what menorrhagia is. They can have joint pain and stiffness because of the bleeding into the joint, which is the hemarthrosis, and that's the picture that I have up here. And you can tell that is a very swollen joint, and that kid doesn't look like he's too happy. Bruising and hematomas, of course, and then that's the hemarthrosis. Life-threatening bleeding for these kids, thank goodness it doesn't happen very often, would be an intraventricular hemorrhage. If they bleed into the iliopsoas muscle, which is in the abdomen, they bleed backwards. So it's not going to be expressed in the abdominal wall, which would be the muscle layer, the fascia, and the skin. It's behind that muscle wall. Because the retroperitoneal space is so large, they can lose a lot of blood without anybody knowing before they have pain and before they start showing the signs and symptoms of acute blood loss. And then the last life-threatening bleeding place is trauma on the neck, because they will bleed into the retropharyngeal space, and that can completely occlude the airway. The pertinent nursing diagnoses for hemophilia, of course, risk for injury. If they have a bleed, then they have acute pain, and that might also lead to the activity intolerance, as well as impaired physical mobility. So the risk for injury is our biggest one that we need to address, especially when we're prioritizing our care and we're giving patient education. Assess your patient for bleeding. We don't want to take rectal temps because we don't want to have that probe initiate a bleed. Whenever we do anything that pierces the skin to access blood, you want to apply pressure for a good 5 minutes. Monitor this child for bleeding. So look at the nose, look at the mouth. If they have a bowel movement, just peek at the stool, and then look at the skin for new onset of bruising and then bleeding into the joint. And then we're going to administer factor as ordered and according to the manufacturer's guidelines. I put another video on Blackboard. It's kind of long, but I want you to pay attention to how factor 8 is supplied, how you have to connect the two vials, rotate them, and then be able to withdraw the factor. And we want to infuse it over at least 2 minutes. We'll give them rest, and if they have a hemarthrosis, you want to elevate that extremity, and we will do some ice therapy. Provide a safe environment for this child, so no running down the halls to the playroom. And think about what kind of toys are appropriate or inappropriate for a child with the potential to bleed. When they come in with this bleeding episode, what you can anticipate is administering the factor, whichever one they're deficient in. This will relieve pain within 12 hours of administration, so you might need to give pain medication also to make them comfortable. There is prophylactic administration of factor. Depending on the child, can be anywhere between 1 to 4 times per week. And they will have a central line placed because, number one, we always need access to a vessel. And number two, they're going to be giving this at home. Now, if you go searching on YouTube, you'll find a little boy who does it himself. He looks like he's about 8 or 9 years old, and he's doing it in a peripheral vein. It's kind of interesting to watch. Look at the cost of giving factor 8 prophylactically, so to a 50-kilo kid, $300,000 a year versus the on-demand. They have an acute bleed, we're going to give factor. It's only $50,000 a year. So based on who the insurance company is and the financial status of the parent, they may not qualify for prophylactic dose. We're only going to give them the on-demand. Other things you may encounter when these kids come into the hospital is if they have a wound, they're going to require packing, especially the nasal cavity. I remember this little boy who came into the ER with his sister because his sister was sick, and he had hemophilia, and he's running around in the ER, and he falls, bumps his nose, and he ended up being admitted, not his sister. And we had to pack his nose. He was a little guy too. He wasn't a happy camper about that, especially when we had to pull it out and repack it. Always monitor their airway. Monitor the bleeding on the packing. So at least hourly when you're making your rounds, you need to look at that packing and make sure that it's still white and it's not having some pink on it, because that means that they have an active bleed. Next thing you know, the whole thing's going to be full of blood. And then assist with the removal or the repacking procedure. A lot of times the docs like to do that to control the bleeding, and once they're fairly stable and factors on board, then it's a nursing responsibility. Our parent and patient education is how to give the factor at home. And this link is the step-by-step administration, a father doing it for his son at home. Pay attention to this kid. It's amazing how young they are and how they just sit still for the whole thing. Providing a safe environment at home. Maintain activity, but really choose carefully. So a low-contact sports, they're not playing football. They probably shouldn't play soccer either, because they have to hit that ball with their head, and then they'll have a head bleed. Make sure that their rooms are free of clutter. When they're brushing their teeth, it's best to use a soft bristle toothbrush, and they can still floss. When they are old enough to shave, they have to be very careful, and an electric razor would probably be better than a straight edge. And then for the babies that have especially the less than 1% of factor on board, the risk of SIDS versus the risk of bleeding, we have to weigh that, and they would probably be a candidate for going ahead and padding the crib so that they don't have injury. These children should wear a medical alert bracelet and be taught the signs and symptoms of bleeding, and that when they have it and they're starting to see a joint fill up, they need to come into the ER for some factor. And the complications of hemophilia in the long run is uncontrolled bleeding. They can also develop a sensitivity to the intrinsic factors that cause the factors to actually work when administered, and then they have uncontrolled bleeding. And then have a permanent joint deformity because of recurring hemarthrosis, and then they have osteoarthritis at a very early age. And this ends hemophilia.